So moving ahead to a very important disorder from which you had a question in your most recent INI-CET November 2022 exam as well. So about cystic fibrosis. The genetic basis of cystic fibrosis is very important. We all know that this is basically due to a mutation in the CFTR gene. Okay. So what is this CFTR gene? It is the cystic fibrosis transmembrane conductance regulator gene. Okay. So it is the cystic fibrosis transmembrane conductance regulator gene. Right? And this gene is on the chromosome 7, long arm of chromosome 7, okay, 31.2. So band 3, subband 1, region 2. So chromosome 7q31.2. So the long arm, at least remember it is on the long arm of chromosome 7, right? And this gene is a quite long gene, and there are many mutations known in this gene. Of them, the most common mutation is the delta F508 mutation. Okay. So this means that there is a deletion of the codon coding for phenylalanine at the 508 position. So this delta F508 mutation is the most common mutation responsible for cystic fibrosis worldwide. Okay. However, in India, this mutation is not so common, and it accounts for almost, say 20 to 50%. Okay. So in India, it accounts for almost 19 to 56% of cases, right? So, this cystic fibrosis is one of the disorders which shows autosomal recessive inheritance, right? So, this information was asked in your INI November 2022 exam. So, the most common gene mutation responsible for cystic fibrosis, right? So, we need to know the genetic basis of this very important disorder. Now, what is the pathophysiology of cystic fibrosis? So, let us see what happens. So there is a basic defect in the chloride channel. So, this CFTR gene basically codes for a chloride channel. So, the chloride channel is defective. Apart from that, there are also some defects in the ENaC epithelial sodium channel and the potassium KIR channel. Okay, but the main defect is in the chloride channel. This was also asked, right? So, let us see what happens. So, suppose this is the respiratory bronchiole that you're seeing, and this is the lumen. Okay, these are the epithelial cells, and that is the lumen. So what is happening here? Because the chloride channel is defective, this chloride channel that we marked in red, this is defective here. So what will happen? Chloride and sodium are not getting secreted in the lumen. So in the lumen of the respiratory tract, the mucus that is secreted becomes very thick and viscid. Okay, so thick and viscous respiratory secretions. Okay, so they are so thick and viscous that the bacteria get stagnated there. Initially there is colonization and later on infection, right? So thick and viscous respiratory secretions which cannot get cleared off from the airway get impacted there, become source of infections, leading rise to recurrent pneumonia and even bronchiectasis. Okay. And on the other hand, in the epithelial system, epithelial cells, what happens? This chloride is not getting absorbed and sodium is not getting absorbed properly. So what will happen? There will be increase in the level of the sweat chloride. Okay. So chloride level increases in the sweat. In fact, this sweat chloride is used as a diagnostic modality for cystic fibrosis. So chloride level increases in sweat because of again this defective chloride channel. Okay. Now, what are the clinical features of cystic fibrosis when we suspect it? So, as we already mentioned, there is difficulty in clearing of the secretions. So, there will be recurrent episodes of infection. So, respiratory wise, there are recurrent pneumonias. Okay, recurrent pneumonias or respiratory infections. Usually, the early cases, okay, early on in life, the recurrent pneumonias are due to the common organisms that are there in the community like Staph aureus or H. influenzae. Okay. Later, colonization by Pseudomonas occurs. Okay. So later colonization by Pseudomonas. And slowly with time what happens, these Pseudomonas undergoes mucoid transformation to survive in the cystic fibrosis patient's airways. So initially there is colonization. So initially we said infection by Staph aureus or H. influenzae, then colonization by Pseudomonas, and then this Pseudomonas undergoes mucoid transformation to survive in the CF airways. So mucoid transformation of Pseudomonas so that it survives in the airways. Okay. However, the pathognomonic organism that, if you are getting a pneumonia due to this organism, then, there are chances that this child has cystic fibrosis. So that organism is Burkholderia cepacia. Okay. So infection by Burkholderia cepacia. Burkholderia cepacia infection is pathognomonic. Okay. Causing lung infection in the cystic fibrosis patients. Okay. So these cystic fibrosis patients eventually are going to develop bronchiectasis. Can you see these dilated bronchioles here? Okay, all are dilated bronchioles, right? So there is finally development of bronchiectasis. And these patients also have, they can have sinusitis, they can have nasal polyps. Okay, they can have sinusitis, nasal polyps, and they can even have atelectasis or collapse, okay, because of the blockage of the airways due to the thick mucus, right? So these are the respiratory manifestations. Moving ahead to the GI manifestations. So these children usually present with recurrent episodes of diarrhea. So recurrent diarrhea, and there is actually steatorrhea. So there is a lot of fat in the stool, okay? Sometimes there is so much fat that, the mother can say that they can see oil droplets in stool. So, okay, so stool has oil drops and the stool is very, very greasy such that it is very difficult to clean. That history can also come, okay? So there is steatorrhea because of the pancreatic enzyme insufficiency, there is impaired absorption of fat. So more and more fat is excreted in the stool, right? So that is why you are having recurrent diarrhea, you are having this steatorrhea, there will be failure to thrive, okay, failure to thrive, right? And initially in the newborn period, you can have meconium plug or meconium ileus. So meconium ileus in the newborn period may require surgery. So in the newborns, this has been asked previously, putting a 3-star here. So newborn period, you can get meconium ileus, and older children have distal intestinal obstruction syndrome, okay, which might require surgery. So distal DIOS or distal intestinal obstruction syndrome, okay, right? And untreated patients of cystic fibrosis also have rectal prolapse. This was also one of the options in one of the questions, true and false questions that came about cystic fibrosis last year. Okay. So rectal prolapse is seen in untreated cases of cystic fibrosis. Right. Now moving ahead to pancreas, we know there is exocrine pancreatic insufficiency. So there is exocrine pancreatic insufficiency. Apart from that, there can be acute or chronic pancreatitis. Okay, acute or chronic pancreatitis can be there. Right? Now, related to liver, there can be cholestasis and there can be biliary cirrhosis. So, cholestasis, neonatal or infantile jaundice can be there. There can be biliary cirrhosis. Okay. In the genitourinary system, there can be oligospermia or azoospermia can be there. Okay, azoospermia and infertility mainly in males. So azoospermia and infertility mainly in males. Right? Okay. What are the nutritional problems in cystic fibrosis? So one we said obviously is failure to thrive. Okay, failure to thrive, fat is not getting absorbed, even proteins are not getting absorbed properly. So hypoalbuminemia and generalized edema can be there. So hypoalbuminemia and generalized edema can be there. There can be vitamin deficiencies, okay, because especially the fat soluble vitamins are not getting absorbed properly. So there can be vitamin deficiencies, okay, vitamin deficiencies. Salt depletion, because excess of sodium chloride is being lost in the sweat, right? So salt depletion. And there can even be metabolic alkalosis, okay, metabolic alkalosis, right? So what are the diagnostic criteria for cystic fibrosis? One is that the clinical picture or clinical features should be compatible. Okay, clinical features should be characteristic of cystic fibrosis. So clinical features characteristic of CF should be there, like we said, recurrent diarrhea, recurrent pneumonia, steatorrhea. Okay. Then there can be a history of cystic fibrosis in a sibling or a first degree relative. Okay. So history of cystic fibrosis in a sibling, or if there is positive newborn screening test for cystic fibrosis. So many countries do newborn screening for cystic fibrosis, and that is done using IRT or immunoreactive trypsinogen, and that is also often asked. Okay, so positive newborn screening test, screening for CF, okay, and that is done using IRT or immunoreactive trypsinogen, immunoreactive trypsinogen, okay, right? So either of these three we want, either any one of these three, plus some investigation findings like sweat chloride more than 60 millimoles per liter on 2 separate occasions. So elevated sweat chloride. So sweat chloride is a easily doable test. Okay, sweat chloride more than 60 millimoles per liter on 2 or more occasions. Okay. So elevated sweat chloride is one criteria among the investigation criteria. Okay. Or detection of 2 CA, cystic fibrosis causative mutations. So, or 2 mutations detected in the CFTR gene, okay, CFTR gene, or abnormal nasal transepithelial potential difference, okay, abnormal nasal transepithelial potential difference, okay, transepithelial potential difference. So any one of criteria on the left side and one of criteria on the right side. So any one from left and one from right, if they are present, then they are enough to make a diagnosis of cystic fibrosis. Okay. Now the treatment of cystic fibrosis, what do? So for the pulmonary complaints or for the respiratory issues, one is, because, the bronchus and bronchioles are getting blocked and there is bronchospasm. So bronchodilators are going to help. So because the respiratory secretions are getting stuck up in the bronchus and bronchioles, and they are getting obstructed, and there is also spasm, so bronchodilators are going to help. So bronchodilators. Apart from that, inhaled 3% saline or hypertonic saline helps in loosening out the secretions. So inhaled or nebulized hypertonic saline. Some people also use recombinant DNAs for nebulization to loosen up the secretions. So human recombinant DNAs inhalation or nebulization. Chest physiotherapy is very, very important. Okay, so chest physiotherapy to loosen out and clear out the secretions. So chest physiotherapy. Okay. Respiratory support if required. And whenever the episodes of pneumonia develop, then you have to give antibiotics. So these antibiotics can be inhaled or oral or injectable. inhaled or oral or IV, right? So that is the management of respiratory issues. Now, about the nutritional management, you have to give a high caloric diet because they have failure to thrive, they're not growing properly. So high calorie diet. You have to, supplement the fat soluble vitamins. So fat soluble vitamins, that is A, D, E, K, and the minerals also need to be supplemented. Okay. And what else? You have to give pancreatic enzyme supplement. So it is usually available in the name of Creon. So pancreatic enzyme supplements are required with each meal to digest that meal properly. So pancreatic enzyme supplements are required to digest the meals. Okay. And apart from that, you will do treatment of complications. So if any complications have developed, like meconium ileus or distal intestinal obstruction syndrome or appendicitis, okay, or rectal prolapse, then you have to manage it accordingly. Okay, right? So these are the things that we need to know about cystic fibrosis, a very, very important topic, often asked in the INI CET exams. So you must know it, right?